Right, so it's 1:03. Okay, so we're going to get started, and as folks join, they will hopefully not miss too much. So, hi everyone. My name is Luba Rafi. I'm the Deputy Director of the Family Law Project in the Manhattan Family Justice Center for Sanctuary for Families. Today's webinar, which is going to be a panel discussion, something we haven't done before, actually. It's a second part of a three-part series that we're doing, where we've been discussing the state of reproductive justice, of reproductive health, post the Supreme Court decision in Dobbs versus Jackson Women's Health in June of 2022. On December 8th, we have our last webinar coming up, which is going to be the national landscape. Center for Reproductive Rights is going to be presenting. National Advocates for Pregnant Women, which is now called Pregnancy Justice, are going to be presenting. So please join us for that as well. Today we have three wonderful local folks joining us, local practitioners and advocates, to talk about how the Dobbs decision has affected their practice here in New York. So just a couple words about Sanctuary for Families. For those of you not with Sanctuary for Families, which I know is quite a few people, Sanctuary for Families is New York's leading service provider and advocate for survivors of domestic violence, sex trafficking, and other related forms of gender-based violence. Every year, Sanctuary empowers 10,000 adults or more and children to move from fear and abuse to safety and stability, transforming lives through a comprehensive range of services, which range from legal representation, counseling, economic empowerment, shelter, and programming for children and families. We're informed by our work with thousands of survivors, and we are the leading advocate for legislation and public policies that promote freedom from gender violence as a basic human right. When we started the subcommittee for reproductive rights at Sanctuary for Families in 2019, which was pre-COVID, pre-Dobbs, even pre-June Medical Center, one of the things that we were talking about at the time is that any restriction on a woman's right to choose on reproductive choice is a form of gender-based violence in itself. And we have expanded our mission at Sanctuary to include that as well. So for this webinar, again, you're going to hear from really exciting panelists. Our panelists today are Dr. Marisa, is it Nadas or Nadas?
It's Nadas.
Nadas. Okay, there we go. I knew I was butchering it. It's Dr. Veronica Ades, who's going to be joining us hopefully soon, and Princess Ward. Just a couple words about our panelists. Marisa Nadas is an attending physician in the Department of OBGYN and Director of Option Services at Jacobi Medical Center and North Central Bronx Hospital. She is also the Reproductive Health Clinical Service Lead for New York City Health and Hospitals, working on system-wide strategy to achieve reproductive health equity for New Yorkers. Veronica Ades, or Ades, I'm so sorry if I'm mispronouncing Ades. Okay. I've said it many times and I'm never sure. So Veronica is somebody that we have worked with in the past. We have had her at a webinar before a couple years ago to talk about the COVID responses in New York City. She's the vice chair of the Department of OBGYN at Jacobi Medical Center. And she also founded the Empower Center. She's the founder and the director of the Empower Center at Governor Health, which provides comprehensive trauma-informed medical and social services to survivors of commercial sexual exploitation and other forms of sexual and gender-based violence. And Princess Ward, last but not least, Princess is a reproductive health navigator with New York Health and Hospitals, supporting patients seeking abortion care who need a little extra help, including scheduling or logistical support and financial assistance. Princess assists patients by removing obstacles, building and maintaining relationships with abortion funds in the region and other organizations providing support to patients seeking abortion care within New York City Health and Hospitals. So just a couple of ground rules. This is going to be a discussion, so I will ask the questions and our panelists will answer them. But we will leave a little bit of time for Q&A at the end. So if you have questions, you can type them into the chat and I will ask them of the speakers. Okay. Are you guys ready? So being as Veronica is going to be joining us a little bit late because she had 5 patients as of 40 minutes ago to still work with. And I know that she's doing some really, really great stuff. I'm going to jump into some of the questions that we have for the speakers that we have. So for Marisa and Princess. So Marisa, your bio says that you're working on a system-wide strategy to achieve reproductive health equity for New Yorkers. Can you talk a little bit about what that entails? It's a mouthful. So just what does it mean in actual practical real life?
Yeah, thank you for that, Luba. And hello, everyone. I'm so happy to see this turnout for people who are really interested in understanding better the abortion access landscape here in New York City. And thank you for making time in your lives to learn more about this issue and care about it. So when I say that I'm working on a system-wide strategy to achieve reproductive health equity, well, the first question is, what is reproductive health equity, right? And what that means to me is everyone, all people, having access to high quality and compassionate reproductive health care, and that includes abortion care. So I want to be able to say that every New Yorker can access abortion care and reproductive health care when they need it, in a way that is comfortable and respectful and meaningful for them. Now, the first step towards me achieving that personal goal of mine is working in the city hospital system, because one way to, one step towards equity is making high quality care available in the public healthcare system. So just working in that sector in general is already working towards that goal. And our city hospital system, provides care to everyone, regardless of income, regardless of insurance status, regardless of immigration status, and with significant financial assistance for people within New York City limits. And so that to me means that in order to achieve reproductive health equity, people have to be able to access abortion care and high quality, consistent, up-to-date abortion care within our system. So step one is expanding abortion care within our system to push New York City towards the goal of reproductive health equity. Within our system, that means looking at all of our facilities, who can and does provide abortion care. What do we think is the basic package of services that should be available at every facility? And then sort of moving towards that. So over the past 5 years, for example, we identified that medication abortion is something that we believe should be available at all of our facilities that provide abortion care. And several years ago, it was not actually accessible at all of our facilities. So we worked slowly and steadily to make medication abortion available at all of them. Secondly, within our system is expanding the services that we're able to provide at a system level, and then really streamlining the referral process so that no matter which facility a patient shows up to, they're going to be connected to the care that they need and in a smooth and easy fashion for them. So really strengthening our network between our hospitals so that patients are able to access that care smoothly. And those are just some examples, but that's sort of what reproductive health equity really means to me.
Thank you so much. And are you aware of any steps that are being taken to facilitate the people who are coming in for reproductive care at this point?
Yeah. So, fortunately, I live and work in New York City, where there's overwhelming support for the right to choose and for abortion access. So, for me, over the last several years, the way that things have shifted is that abortion care is rising on people's priority list, right? As we see that there is this human rights crisis and that our role in that crisis is increasing provision and access. So, people that haven't previously been involved in abortion care are seeking out ways to support this service and to be involved. And there have been so many new initiatives coming from the bottom up and also from the top down, because there's a lot of interest in leadership, recognizing that this needs to be a priority of their systems and institutions. So with that being said, there has been a lot of citywide collaboration and conversation around how to improve visibility and access for people who maybe not only are within New York City, but outside of New York City. So how do we make it easy for people to connect into care in our city? And we've been working very closely with the New York City Department of Health and others in having those conversations. So, you know, for example, like the New York City Department of Health just launched an abortion access hub that is essentially a navigation hub. It is a phone number that anyone can call and say that they want to know more about abortion care in New York City or be connected to abortion care, and they're like a wheel, you know, with spokes going out to all the providers, and then they're able to connect people to care. So a lot of work around just easing that process of finding an abortion provider in New York City, and then improving the collaboration and the way that we work together to streamline those referrals. And then the third thing I would say is really looking at how to reduce the cost for people paying out of pocket. So, you know, for New York City residents, there's huge financial subsidies for care if it's needed. Certainly within our public system, we have heavily subsidized care and so many resources to help patients figure out what they're eligible for and how to access it. But when patients are traveling from further away, then they may not be eligible for those subsidies, and they also may have insurance. If they do have insurance, then, you know, maybe the provider that they're finding is not in the, you know, is not an in-network provider or whatnot, or is not covered. So there's been a lot of conversation in New York City and work being done at lots of facilities to figure out how to reduce the cost for people who are needing to pay out of pocket. And then lastly, it's just as people need to travel further for abortion care around the country, there's an increase in support for those logistics, the logistics and the travel, because that makes abortion a higher cost service to access.
Thank you so much, and we'll get back to you with some more questions. But I wanted to jump to Princess, who, if I understand correctly, deals a lot with logistics as well. So Princess, we're not quite able to see your face. If you want to just tilt the camera a little bit, we'd love to see you. We're seeing a lot of hair. Okay, all right, now that's good. So welcome to you as well. So a couple of questions for you. So what would you say are the typical barriers to communicating with patients, and how do you overcome those? If you can talk a little bit about that. Oh, nope. No, you're muted. Nope. Okay.
Hello, everyone. So for me, it's usually a smooth communication process when I initially get the referral. One of the barriers that I face a lot is actually the follow-ups. So trying to reach the patient again to confirm certain information, which can range from financing or appointments. A lot of times, and recently I've dealt with, you know, patients not returning calls, or they might have changed their mind. Some of them can also be nervous. So what I do a lot now is always asking for an emergency contact. Is there someone that I could reach out to if I'm not able to reach you? Also, texting is real good with some of the patients that I deal with. They respond quicker to text. So the initial contact is always smooth. A lot. Sometimes they answer right away because they want the service, but it's usually the follow-up calls. And that's just, you know, confirming certain information. A lot of times they might end up changing their mind or decide to go see a provider within their state, because I also try to explain what's available out there as well. A lot of them don't know, so you try to provide as much information as possible. And we want them to come to New York City Health and Hospital, but if something is available, it might be closer, then, you know, I try to let them know about information that's available there so they can have access to the service.
What would you say? So obviously you deal with a lot of patients, you know, and you coordinate a lot of care. What are the most common questions that you get from patients?
What is my role as a reproductive health navigator? Because it's so, you know, new. A lot of them are worried if they don't have insurance, what would be the process? Would they be able to get the procedure done? Questions about the location. And honestly, a lot of them are very shocked by the services I'm able to assist them with. So a lot of the time and also the cost, the price. That's a real big one. A lot of them don't know. And then sometimes we have to follow up, but it's definitely the price a lot of the times. And then exactly what my role is. And if their insurance will cover it, if they don't have the money to do it, would they be able to get assisted?
And you, of course, again, as a coordinator, you are dealing with the other side of it, which is the doctors and other medical providers. So what are the most common concerns that doctors and nurses have from your experience?
So I just came on, well, I started getting referrals in September. My role was brand new, so I did a lot of visits to the facilities. A lot of times I'm communicating with, the PCPs via email. So right now, I think it's mainly what we've discussed is just like streamlining the process of having, access to abortion care. Making sure that the process is streamlined as far as, patients be able to get the service. Also having a shorter wait time as far as them coming in, or, they might have to come back, for the actual appointment because they have the intake. So, trying to streamline the process and making it as easy as possible for them to have the access to care.
So other than that, obviously your position in a sense was created with Dobbs in mind, with the idea that New York wants to, if anything, boost their reproductive access to people who need it. But what would you say have concerns from patients and medical professionals noticeably changed since the Supreme Court decision in Dobbs?
So I would have to say, I don't want to say it has changed from the patients that I've worked with. The patients that I've assisted with, they're just mainly shocked by the services that's offered by me because I'm the navigator. So it's mainly them being shocked by what I offer as far as like the travel, the expenses, the logistics care. So a lot of them are usually shocked about it. And I wouldn't say it's changed because this is my first experience with it since I came on in September as far as the ruling. So since I came on, a lot of the patients have just been more surprised by what's offered, especially if they're coming from out of state. I had one that it was an international patient, just to give an example, and they wasn't aware of how much help they was able to get, and they was coming from Barbados. So that's been my experience with it.
It's really pretty amazing to hear the silver lining, especially considering that, when we read the news, everything we hear is absolutely grim. So it's really pretty refreshing to hear how New York is handling this, of course.
Yes.
So have you seen, and this is a question for Marisa, have you seen conversation around reproductive rights change in the last 5 years in general? Like, what would you say were the big changes, even pre-Dobbs and especially post-Dobbs?
Yeah, I will talk about that. And I also was going to give a follow-up to the question that you were just asking, Princess. And since I have been working, in this work pre and post-Dobbs, and Princess, really started after the Dobbs ruling. So all of her experience has been in this current climate, I think. But we really do see so much more hesitancy from people and confusion around what is accessible in their area, even living in a place where it continues to be legal and accessible, like New York State. We have heard from multiple New Yorkers that they don't know if they can still get an abortion in New York, or are they going to get in trouble, or what are going to be the consequences. So definitely for people seeking abortion care, there's so much more hesitancy and fear out there. And that, is part of the agenda of the anti-choice movement, is creating that level of confusion. And so there's so much public messaging work being done to try to counteract that and be very, very clear in what's available here. We're fortunate that Governor Hochul launched a huge, public messaging campaign around abortion access. You can, arrive at JFK, and at baggage claim, you can see signs that say abortion is safe, legal, and accessible in New York State. But that's not unwarranted. It's actually very, very needed because the confusion is profound. In terms of providers, I think that providers, for the most part, have just sort of like increased their desire to expand their reach and expand access. Although there's certainly a lot of conversation with the legal support at various institutions around, so many questions come up around like what happens with out-of-state folks, what does it mean depending on what the laws are in their current state. And so everyone's always asking those questions, and there's so much that remains to be seen as things unfold. To get to your second question in terms of how the conversation around reproductive rights has changed in the last 5 years, I think that I was largely kind of answering that, I guess, in a previous question, just talking about how it's sort of just continuously risen as a priority in our institutions as people feel this, reversal in rights across our country. In a place like New York, a lot of people see that our role is really how do we expand and expand our reach to as many people as possible. So, the initiatives that have been coming up, the new initiatives in the last year or two have been coming from more places and from the top down as well as from the bottom up. And then also just the increase in funding. I mean, there's been a lot more funds available for abortion care now than there were even a year ago. And it's because, people see that that's what our role is.
Has your client population changed in the last 5 years? Would you say that you're seeing different folks than you've seen before?
I don't think that our client population has changed that dramatically. I mean, in the city hospital system, the vast majority of our patients are New York City residents, and that has always been like that, and it continues to be like that because that's really our catchment area, and that we are completely devoted and focused to serving that group. Now, I know that the next question or a follow-up question is going to be, just how have our patients changed since the Dobbs ruling? Are we seeing an increase in volume, et cetera? And everyone has that question. And I can say that we are seeing an overall trend in increasing gestational age in the people presenting for care, which we, can partly be attributed to people needing to travel further for care. But even among New Yorkers, as I was saying, there's this general hesitancy around abortion care. And so I think that even people within New York are delaying a little bit. There's a little bit more fear, a little bit more stigma around it. And so even New Yorkers are seeking abortion care just a little bit later. So we are seeing that difference. And then we are also seeing people, across the country just need to travel further for care. And we're seeing that within states and across state lines.
So I guess the unfortunate sort of result that's achieved by the Dobbs decision is that it went from a very difficult and personal decision, but nonetheless logistically simple one in New York to now being something that people hesitate whether this is the right thing, whether there could be consequences or repercussions. So unfortunately, in that sense, I guess things have changed from what I'm hearing from you.
Yeah, I think that it has changed some for people who are actually seeking the care. Even though from our standpoint as the providers, we haven't seen a huge change in our volume necessarily, but we are seeing those changes that I was suggesting.
And question for Princess. So I know you mentioned this already. If you could just expand a little bit. So are you encountering many patients traveling to New York for from abortion restrictive states? So obviously, all of us are thinking Texas, Oklahoma, those are the states, that are in the news. Are you seeing patients from those states?
I actually got a patient from Texas last week. And that was a patient that was referred to me from the DOH abortion hub. So we are getting patients that are coming from out of state, and some of them are coming from restricted states as well.
And can you talk a little bit about, again, obviously understanding patient confidentiality, but, what is their reaction sort of to coming into New York and to interacting with you, if you can speak a little bit to your experience with out-of-staters?
I'm actually happy to share that because I actually had two. The first one that came international, she and she came with her mom, and I did a lot of communication with her mom, you know, as per her permission. And she was just crying, and she was just, I have some text messages that are so sweet. One of them, because so they don't get to meet me, so all my communication is via phone with them. So she thankful, telling me, you know, I'm so grateful for this and the help that I received. One of the moms, when I believe she went to, I think this was maybe NCB, I believe, and she was like,
And
everybody.
sorry, just for those of us that don't know the
North
abbreviation.
Central Bronx, North Central
Okay.
Bronx, one of the facilities with New York City Health and Hospitals. And she stated how nice everyone was, and they appreciate, you know, everyone being so warm. And I feel like if a patient feel like they can speak to you and express their concerns, that make it even more better when everything is done. And she felt it not only from me, but also from some of the providers and the staff that she met at the facility. So it has been very emotional for some of the patients, and a lot of gratitude to the help that they offered, especially where they're coming from. And some of them that I was able to help with hotels. A young girl, when she called me back and she went back home, and she was actually coming from Florida, and she was just like, thank you so much. And I try to do a check-in with them afterwards to see how they're doing. So it's been a lot of gratitude, and a lot of them being more aware of the services and the help they can get. So it's been good.
I'm sure it's been a breath of fresh air for them as well. And so for those folks that would be seeking services through you. So again, I understand that the position is new, but how do people find you? How would they find you? How would they get in touch with you?
So usually how the process takes place, if they're coming internally, once they make an appointment or speak with the PCP and sometimes the health educator, they identify if they need to work with me as a reproductive health navigator, and then their information is passed on to me. It usually can be done via email, but once it's identified from like the PCP or the health educator or external resource at times, then I reach out once I receive the phone number and the information. And I usually reach back out within 24 hours.
So for example, some of us, myself included, work in direct client services, and, you know, we have people coming into the Family Justice Center that are seeking obviously services for their domestic violence situation, intimate partner violence. And sometimes we get patients who are pregnant who want to terminate their pregnancy. My actually decision to start the subcommittee at Sanctuary came from a pregnant client, you know, who came in and asked the question of, you know, what will my life be like if I have this abortion? She's been married for like 6 months, you know, nothing else in common, versus if I have this child. And I was like, I can't talk to you about this. I can only talk about the legal stuff, but, you know, so those folks that are coming in, can we make the referral to you, for example, being a completely outside source, not a PCP? Would that be something?
Yes, you can. And how that works is I usually share my contact information with you, and then you don't give them my information, but let them know they can receive a call from me. I have a document that I use, which is like the referral. I can email it and share it with you, and also share some of the facility information so you're aware if they have certain questions. So you can actually email and also call me as well.
That's wonderful. So that's a great resource. And you know, for folks at Sanctuary, if you need to seek out Princess, we now know that, you know, she exists and that she could be helpful to our clients.
Yes. And then I'm sorry, I just wanted to give another way. If you share also, or they want to reach out to the, you know, the DOH abortion hub. I recently, and this was this week, got a client who was it was human trafficking, and it was an advocate who reached out, and she was pregnant and she wanted the assistance. So even reaching out to them, thankfully, I'm one of the first, you know, they have a lot of external resources, but they call me first a lot. Even that way is another way to reach me. Going through them is another way to get, you know, referred to me for services.
Thank you so much for that. That's really, really helpful. And are there any organizations that are assisting patients that are traveling to other states to obtain abortions in New York City? And what are the services that those organizations provide?
As far as the traveling, so one of the main organizations that I work with is the Bridget Alliance. So I have been communicating with them and they've been able to assist with them traveling. I've been able to get hotels. Some people might drive to New York and they also assist with funding for that as well. I also work with another agency that's Haven. They don't assist with traveling, but they also help with some resources. So but the main one for traveling is definitely the Bridget Alliance. And I'm building more resources as I go.
I mean, it's pretty amazing what you've been able to accomplish, you know, in such a short time. If you can, you know, so Veronica is actually emailing us right now. She's looking for the link. So I'm going to ask you another question and then I will usher her in. So your experience pre-starting this position, you know, just if you could talk a little bit about why you decided to join this movement, why you decided to take this on, just a little bit of, you know, about that.
So just to give a little bit about my background. So before I came on to New York City Health and Hospitals, I had worked in social services, the human services field, where I dealt with helping a lot of people who dealt with mental illness. Some of the population might include homelessness, the LGBT community, and also clients who suffer like from substance abuse disorders. I came from health homes, but previously I also worked at Planned Parenthood. So for me, you know, I believe, you know, every woman has the right to make their own choice and they should have access to services. So not only professionally, it is something that I love to do, but personally, it's something that I stand behind. So that's why I decided to come on to support women, to support access, and I enjoy doing it. And I've been working in the human services field for now, I would have to say over 9 years. So to be able to come over to New York City Health and Hospitals and be able to do it, it's been a great experience and a learning experience too, especially working with all the doctors that I work with now and also working with Marisa, who's been very helpful with me learning a lot of things about women's health as well. So that was one of the reasons I came on.
Thank you so much, Princess. And speaking of doctors, so Veronica has joined us. Veronica, I already introduced you and spoke about all the wonderful things that you have done pre-Dobbs. So I just wanted to talk to you a little bit about, and this is, you know, obviously an issue that's near and dear to folks here that do work at Sanctuary. So you focus your research at the Empower Center on sexual and gender-based violence. Sexual trauma, which is, again, very relevant to our work. Could you please share some of your recent research on this subject?
Sure. So we look at a variety of aspects of sexual and gender-based violence. We have work on sex trafficking. We have a study that looks at the patients who have presented to the Empower Center and looks at what their medical, OBGYN, and psychiatric health needs are. As well as some of their outcomes. We've also published on our model, which is pretty unique, our model of comprehensive care. And we're actually about to publish an update on that model because it's not very common throughout the country. And we are also looking at subjects like sugar dating. We find that actually a lot of college students are taking on sugar daddies, either to pay for additional items or to pay their tuition, which is a little bit alarming. But it's also kind of manifesting in different and interesting ways. So we're studying how it does manifest and what that looks like. It hasn't really been well described. We're also doing a study of intimate partner violence. We find that it's often screened for in women or screening for victims, but nobody really screens perpetrators. So we're actually looking into the literature to see if there might be a role for screening of perpetration of intimate partner violence, because really it's the person doing the violence that can stop the violence, but we tend to not look at that side or really offer interventions in that way. And we're actually finding that there's a lot of literature supporting this kind of screening, and that potentially we're going to advocate for some change to the national recommendations around screening, because there aren't any for screening for perpetration at this time. There also are no recommendations around screening men. Then we also are looking at things like female genital cutting. I have a lot of patients who have that, and kind of looking at the consequences of female genital cutting, also known as mutilation. We also did a study that we're about to publish about why homelessness in pregnancy is really so dangerous and bad. What's so difficult about being homeless when you're pregnant, what's so traumatic about it, and why it could be associated with adverse pregnancy outcomes other than lack of prenatal care, which is one of the aspects. So as you can see, it's like a wide range of topics, but a lot of them are really important, interrelated, and have implications for health.
Fascinating. I mean, that's a lot. Just right there. If you can talk, two questions, I guess. So if you can talk a little bit about what, succinctly, what is Empower Center, for those folks that are not familiar with it. But also, getting us back to the subject that we're discussing, I wanted to see if you could generally speak about what, if anything, has changed in your experience with your patients past the Dobbs decision in June.
So the Empower Center is a comprehensive health and care center for survivors of sex trafficking and others who are in the commercial sex trade. That includes people still in the commercial sex trade or people who are no longer in the commercial sex trade. The idea being that these individuals often need a lot of support, and really, so they might come for medical care, but also need a lot of kind of social services, and that providing those things in silos often doesn't meet their needs. That often the vulnerabilities that led them to commercial sex or that allowed them to be vulnerable are still present. And if you only address one aspect of it, or if those things aren't working together, it's very hard to actually bring people up and kind of help them become independent. And so our team consists of medical personnel, myself, the OBGYN, we have a primary care provider, we have a psychologist, and then we have some per diem psychiatry access. And then on the social service side, we have case managers, a peer care navigator who's a survivor of trafficking herself and is an incredible support to survivors. We have an economic empowerment specialist who helps with things like writing a resume, getting English lessons, going to job fairs, job training, and then we have a full-time lawyer. And we meet weekly to discuss different cases because often the problems that people are having are interrelated. They might have mental health challenges that are affecting their legal case, and because they can't have mental health challenges, they can't get employment. So if we work on these in silos, they would be very difficult to tackle, but by working together, we can really help people. And we've seen some incredible successes of people who were really at their most vulnerable and really having a lot of life challenges. And by kind of providing support on multiple fronts, we're able to help them become like sort of independent and stable. So that's really rewarding. If anybody is curious about the Empower Center, you can look up the website. It's theempowercenter.org. Don't forget so theempowercenter.org. And if we are only in New York City, we can see people at Gouverneur in Manhattan or at Jacobi in the Bronx. And in that website, there is a link, a referral link. So if you wanted to refer somebody to the Empower Center, you can fill out that referral link and our intake team will contact them. As an aside, I also, separate from Empower, although part of the larger umbrella, see patients who have experienced other forms of sexual and gender-based violence and want trauma-informed care, but don't need the full comprehensive care thing, which is really for survivors of commercial sex. So you can also fill out the same referral form, and those individuals can see me for OBGYN care without the rest of the package. I want to put the website in the chat, although I
already did.
Okay, I think the chat only goes to us. Does it go to the participants?
No, it goes to everyone.
Perfect.
So
okay.
That was me asking you, Veronica's.
Yeah. So that's the Empower Center.
And so, one of the things that was really concerning prior to the Dobbs decision was the effect that it will have on the most vulnerable populations, and there have been many amicus briefs that were specifically speaking to that, and how it will affect even more the marginalized communities, the LGBTQ communities, and frankly, those are the communities that you deal with the most, it seems, at the Empower Center. So what has been your sort of impression? What have you seen since Dobbs, if anything at all?
So it's important to remember that people who are trafficked are often so vulnerable in many ways that predates even the trafficking, right? Many have survived childhood trauma, including childhood sexual abuse or foster care or family instability or family violence, poverty, maybe are undocumented. There's a lot of vulnerabilities. And those are the people who are also most vulnerable to adverse health outcomes, unintended pregnancy, and adverse pregnancy outcomes. In fact, most of the trafficking survivors that I have seen actually self-liberated and are living in the community, but are often vulnerable to other forms of exploitation and violence, including domestic violence. So those people often have, reproductive health challenges. And they often don't wear a flag that says trafficking survivor or trafficking victim. And they look like just another person or another patient. But because they're so vulnerable and because they really lack a lot of social and economic power, as well as often have mental health challenges, if they, let's say, have an unintended pregnancy, among other potential health challenges, it can be even scarier, even more difficult to access the right amount of care. And the trauma that they have survived has actually been shown to be associated with adverse pregnancy outcomes and other health outcomes. I think what people don't appreciate about access to reproductive health care, including abortion, is that it's all part of a package. It's all part of a circle or a spectrum. And when, let's say, somebody comes for abortion care, they're also getting screening for violence, screening for exploitation. They're also getting contraceptive access. They're also getting information about how to access primary care. And many people aren't coming for those other things. And so when they come for that one point of access, whether it's pregnancy prenatal care or abortion care, they're getting entered into the system. So you end up risking losing the opportunity for that person to get connected to the system. And you end up feeling, I think, further vulnerable. I mean, somebody who's being commercially sexually exploited, who has an unintended pregnancy that they then can't terminate, is then going to potentially have that child and be even more financially in debt. And that's the other thing to recognize about trafficking. Most people are not trapped in a room. They have significant financial vulnerabilities, and many of them have children. And although they usually love their children and really want to have them, it makes it very, very difficult for them to be financially independent. And so lacking kind of full reproductive freedom risks further making people further vulnerable to exploitation.
And I mean, it's our understanding that access to abortion care can be sort of part of that power and control wheel for abusers, which I think is what you are also referring to as well in this.
Yeah.
And have you seen any sort of significant change in the client population that you serve in the last 5 years, but also post Dobbs?
Something I've seen in the last few years, when I started Empower in 2013, the bulk of the traffic patients that I saw were young Latina women coming from Mexico and Central America. But there were definitely other pockets of people. There are domestically trafficked people, right? Because trafficking doesn't require crossing borders. So you can be born in the Bronx, raised in the Bronx, and trafficked in the Bronx. It really just requires exploitation for labor or sex. And so foster care there's a foster to trafficking pipeline, et cetera. But the bulk of people that I was seeing were Latina women. And that really, it like turned off a hose. They almost disappeared in the last, I would say, 5 years. And I don't have totally an explanation for why. So that's interesting. So the people that are coming to us now, there's a lot more domestically trafficked people and a lot more kind of complexity, kind of social and psychological complexity to the patients that we're seeing. But it worries me because many of the Latina women that I was seeing before, they weren't actively being trafficked, they were post-trafficking. And so presumably they're still out there in the community. And it worries me that they're afraid to come forward, afraid of being criminalized, or for a variety of ways, including document status. And that, as I said, many times the only thing that they're coming forward for is reproductive health care. I'm in New York, so I'm really lucky. I work with Dr. Nadas, and I feel really, really fortunate to work in a place that's relatively unaffected by Dobbs. But it's also important to remember that a lot of the patients that I see, especially the ones who have survived trafficking, go between multiple states, especially along the East Coast, and are often going between blue and red states. And so they're going into states where it's totally different. There isn't Medicaid expansion, and sometimes abortion is illegal. I recently met with a patient who has been in New York for a long time and I just found out that she's a trafficking survivor. And she didn't know that there were any resources, but she's moving to a state that both has an expanded Medicaid and has banned abortion. And I don't think she totally realized the implications of that she wouldn't be able to access the medical care that she has. She's on Medicaid in New York. And she's not particularly informed about it. Like when I said that to her, she's aware of the general milieu in the country, but did she know that moving to that other state was going to take away potentially all of her healthcare and her reproductive access? Not really, right? And so many of the patients that we're seeing aren't totally informed about exactly what the different things that they do in their life. I see patients going between New York and South Carolina, New York and Florida, New York and Georgia, commonly, all the time. And may not be, totally up on politics and understanding in each state what is different. And so there's a lot of risk there in that they may think that things were the way it was in New York, and now all of a sudden they're kind of trapped here.
It's very interesting. I think one of the concerns that we, when we started planning this webinar series and started, speaking to folks, one of the concerns that I think has been floating is that with an influx of out-of-state folks coming in, that New Yorkers will have more limited access to abortion care. At this point, from what you're seeing, do you feel that the resources are, and this is a question for everyone really, do you feel that the resources are stretched, or do you think that New York has so adequately addressed this that if anything, kind of there's enough to go around for everyone?
I can weigh in on that. I would say that that right now we are not. I don't think that we are stretched to our limits in New York. I think that we still have significant capacity to provide comprehensive reproductive health services, including abortion care, and that we see people from out of state because there are so many connections to New York City, and people travel to New York City from all over the country because it's a place that is either easier for them to get to, or because they have some sort of family or friend connection. And so they have sort of an anchor here in the city. But most travel for abortion care is by car. And we are not bordering the states that have severely restricted abortion access. And so we're not seeing that influx for people who are traveling by car to the nearest abortion facility. We're seeing the people who travel to New York because New York City is the place that feels more comfortable for them to travel to. So no, I do not think that New Yorkers are losing access to care. And I don't think that that is necessarily going to be our future. I think that we are one of the places that is most saturated with healthcare providers, reproductive healthcare providers, and abortion providers. And that we are, always looking for ways to expand and strengthen. And there's always so much room for improvement, but I don't think that New Yorkers are at risk for losing their access.
It's so great to hear. I'm already a little bit dreading our national webinar on December 8th, where the Center for Reproductive Rights is going to talk about all the horrible things that are going on all over the country. So it's really refreshing to hear how New York has stepped up to this. I want to go to the question that we were asked. I know that we don't have a lot of time left. And by the way, folks have questions, please put them in the chat now so that we can make sure to answer them. But I think that sometimes people don't kind of understand the very basics of, of abortion access in New York. So, one of the, so we had Maria Meneses, I'm sorry if I'm butchering your name, say that some patients make questions such as if the AB is illegal services and until what gestation time is allowed. So I believe that, the question is, when is abortion legal in New York? What are kind of the basics that we can tell our clients who come to us?
Sure. And I wrote into the in the question and answer sort of what the law says, but I'm happy to reiterate it. So we are currently operating under the Reproductive Health Act. That's our abortion law here in New York State that was passed in 2019. And so that was the first update to our abortion law since it was made legal in 1970. And so that, the changes that were made from the 1970 law were really just to codify what was in Roe v. Wade in the event that Roe would be overturned, which is where we're at today. So the Reproductive Health Act says that abortion is legal in New York State at any point in the pregnancy if the life or health of the mother is at risk, or in cases of fetal non-viability, so some sort of anomaly affecting the fetus that makes it not compatible with life. And furthermore, that it is available without a need to provide a reason or justification up to 24 weeks from the commencement of pregnancy. Now, there's been much discussion and interpretation over the years around what commencement of pregnancy means, and that's the same wording that was in the 1970 law. So our law, in terms of that, has not actually changed anytime recently. But the most recent interpretation of that from the New York State Department of Health is that the commencement of pregnancy is implantation. And so, what that means down to the day is actually a topic of much discussion, but I think that it is very reasonable to say that it is available throughout the first and second trimester in New York for any reason. And then even beyond that, in those cases where the life or health of the mother is at risk, or in cases of fetal non-viability.
Thank you very much. I think that that's really helpful, again, just to kind of get the grasp of things. And Veronica, question for you. So what do you think, especially in your work, working with the vulnerable populations, and of course, Marisa and Princess, please feel free to weigh in on this. What do you think are the more, like the greatest barriers to people seeking abortion care? And obviously this is, relevant to your practice in New York, but I'm sure that that this can be extrapolated to anywhere in the country.
So, one is that even in New York, and I agree with everything that Dr. Nadas said, people don't know, they don't know that it's accessible. They don't know that they can get financial assistance and coverage for it. Sometimes they don't even know that it's legal. Like, we have people coming from other countries where it is illegal. I've even seen people taking, medications that they bought on the black market elsewhere here and saying to them, you totally could have come here. And they said they didn't know. They came from a country where it was illegal. Right. And it's often still safe when they take those medications, but I'd rather them be under our care and have somebody to contact should anything happen, and also have the opportunity to introduce them to care. So that's one thing, is lack of knowledge. The fact that we don't have universal health insurance in this country is a huge obstacle. And although New York State is pretty amazing about finding coverage, pretty much all pregnant women in New York State, regardless of documentation status, are eligible for Medicaid. And in addition, our health and hospital system, which I'm very proud to work for, has a way of providing coverage for individuals who are not otherwise eligible for insurance. So New York State is pretty incredible in that regard. But even then, because people know that in America, you can't really get health insurance, it's hard to get. They just don't know that if you need a PAP, if you need a colonoscopy, if you need a surgery, if you have a symptom, we will find a way, especially within health and hospitals. So people stay away from care because they hear all these news things about the cost of insulin and huge medical bills. So the fact that even though in New York, we have a very good system, everyone hears the national statistics and data and information. So it keeps them away from care. So it's actually really interesting to see how much the national milieu and the states that really restrict healthcare access affect us. Many of our patients don't know, don't understand, or they come in because they're desperate and they have to, and they go, how much is this going to cost me? Oh my God, I'm terrified, right? And so, so that's really depressing. I think also, New York is doing it piecemeal. And so we put it together and we have very strong support, but we do live within this country. As I said, our patients go between states. Our patients don't often know that New York is different from other states. Or you have somebody coming from New Jersey, just across the border, right? Like, you take a PATH train, and it's different what you can access, or Pennsylvania, right? Or many of the states that we border. And so I think that that's really depressing. They are in the same country that we are, and don't have the same level of access. But also that New York does this at significant cost to New Yorkers, and that the more that you do as a group, the less it costs. So if we were to do this as a national effort rather than a state effort, it would actually be much more efficient, much more effective. It would change our hospital systems in a way that responds to a national healthcare program. But rather, New York State is finding a way to cover everybody in a setting where private health insurance and private healthcare is prioritized, and that leaves most people behind. So there's so many reasons why we're all affected. And the same goes for Dobbs, right? Although we're very lucky to be in New York, it doesn't mean that we're not affected by the national environment. And the most vulnerable people are always the ones who get left behind. And then as a second rant, I'll just say that we tend to blame individuals for their misfortune and for their difficult circumstances. And that's absolutely the wrong way to think about it. You got diabetes, it's your fault. You know, you got cancer, your fault. I mean, it's not. Some people are just going to get sick. Statistically, we know that. Certain number of pregnancies are going to be complicated. People have to have babies, but we act like, well, if you got sick, you probably didn't eat the right thing, did something wrong. Same thing with many of the conditions that we blame on individuals, such as substance abuse, obesity, smoking. Many adverse health behaviors are very strongly associated with trauma, which is my whole area of focus. And it makes you rethink how we're viewing those negative health behaviors that we say lead to adverse health outcomes. Actually, many people do have significant traumas that they haven't disclosed. And when I reveal to them how much those traumas are associated with many of the health behaviors that they're struggling with, it's a huge relief, right? That it's not just you, you're not a weak person, but you were kind of set up to have these issues, and so many other people in your position do. You know, so in America, we're very focused on the individual, but it really is about a collective. It really is about a society. And so much of what society does to people has these individual level health impacts. And so, you know, we need to also handle that as a society.
As somebody who takes the PATH train every day, I strongly agree about the difference between states. So I definitely appreciate that. So our time is running out at this point, and I just wanted to thank all three of you for coming in. This has been absolutely fascinating. We recorded this webinar, and if you guys don't mind us sharing it with folks who couldn't make it, I think this is such a wonderful opportunity for people to hear, first of all, the good news, what's going on in New York City, you know, but also, you know, just to stay vigilant and to remember that we're part of a bigger problem, so to speak, in the post-Dobbs world. Thank you very much, everyone.
Thanks.
All right, take care.
Thank you so much.
Bye.